Okay, so we talk about fundus changes. We just mentioned about cupping of disc. I was just talking about cupping of disc. We will first understand what do you mean by cupping of disc. Please make the diagram which I am making for you. So let's see if this is an optic disc. This is an optic disc, right? So the central pale area inside the optic disc, this is suppose the cup. Okay, so if this is normal optic disc, there is a small area which is little paler, more paler than the rest of the disc. As you can see here, this is your cup area. And the rest of the area outside the cup, this is what is called neuroretinal rim. So here, this and this, right? So this is your neuroretinal rim. What does the name suggest to you all? What is a neuroretinal rim? It is an area which is occupied by the nerve fibers. So we all know already that optic disc is the area from where the nerve fibers from the whole retina, the nerve fiber layer of the retina is aggregating at the optic disc, exiting out and forming the optic nerve, right? So now we are saying that what is the part occupied by the nerve fibers? It is the neuroretinal rim, right? So what is the cup area? Cup is considered a non-neuronal area. Got it? So the nerve fibers are occupying the neuroretinal rim from where they are exiting out, and the central small pale area is the non-neuronal area. Now normal ratio of this cup and the whole disc is called CD ratio. Now you know what is CD ratio, right? So what is CD ratio I am saying? It is the cup area and the disc area. So the normal CD ratio, if they ask you what is the normal value, it is less than equal to 0.3. First of all, this is your exam question. It is less than, I'll just repeat this. I'm saying that the normal CD ratio is less than equal to 0.3. So if this ratio increases, this is what is called cupping. Keep listening. If this ratio increases, we are saying it is cupping. So if the ratio is increasing, which area is increasing? Area of the cup. So could we understand this? When I say area of the cup is increasing, means non-neuronal area is increasing and the neuroretinal rim will be thinning down. So when the cup area is increasing means this is getting damaged. The non-neuronal area is mainly, it is remodeling of the lamina cribosa due to the proliferation of the astrocytes and glial cells, which looks like cupping. You just read that? So let's understand this. So that there's another question. Do we really suspect a patient of glaucoma if the CD ratio is 0.3 only or a little more than 0.3? No. So generally it is saying that we should start suspecting when the CD ratio is more than, according to the latest edition, it is 0.7. Even 0.6 can be taken as a correct answer. So you can see how much variable it is. But yes, if you have to answer an MCQ, we should be very, very sure which one to pick. We'll pick 0.7. I'll start doubting this case, or I'll start worrying more if it is more, if a patient is coming to my OPD and I see a 0.7 cupping, immediately I'll go for glaucoma workup. To be very honest, if it comes anything more than 0.3, ideally should be tested. Suppose the question they ask you, which is the normal CD ratio, we will always say normal that is considered is this one, okay? So a normal CD ratio will be around less than equal to 0.3. The normal CD ratio will be less than equal to 0.3. Okay, but we are suspecting and we are worrying glaucoma, or we are worried when we find a CD ratio of anything more than 0.6 or 0.7. Both are correct. Am I now clear? So we are saying that the cup disc ratio, the cup area is increasing, and this cup area, what is cupping? I have just explained you how there is a remodeling of the lamina cribosa. So damage of the nerve fibers, thinning of the axons and remodeling due to glial proliferation is leading to this cup area. But to simplify, it means Damage of the optic nerve and increase of a non-neuronal area. Now, if you see the cup that I have drawn for you all, I have drawn it vertically oval. So why? Is this not cupping? This is also increase of cup area. Yes, it is. So why do, when we say glaucoma, we are very particular to draw like this? So let us understand why the cupping in glaucoma is always first vertically oval. This is because, let us make this diagram and understand something here. I hope you're drawing along with me. This is your optic disc, this is the macula. So just now I told you all the nerve fibers from the whole retina will aggregate in the optic nerve and will aggregate at the optic disc and form the optic nerve. Right? Now this diagram we are going to learn how is this aggregation taking place. So the fibers from the macula to the disc, they travel straight. This is called papillomacular bundle. So this is what is papillomacular bundle. Papilla is disc, other name for papilla. It is an area where the optic disc is situated, that is called papilla. So papillomacular bundle. Fibers from the temporal side, and this is the nasal. This is nasal, everybody knows that macula is temporal to the disc, so this becomes the temporal side of the eye, retina. So first from the nasal side, the fibers will travel straight, and this is what is called superior radiating fibers, and these are inferior radiating fibers. Fibers from the temporal side, very important, they curve around the macula and enter the disc like this. And what are these known as? This is your arcuate fibers. So we are saying that glaucoma is damage of the optic nerve, right? But not all the nerve fibers are going to be damaged at once, isn't it? So which are the fibers which are damaged first? It is arcuate fibers. I want you all to make a box and write this, very, very important. Write down, I am saying. This is first damage, make a box like this and put it there, it's very important. The first damage in glaucoma occurs in arcuate fibers. The first damage in glaucoma occurs in arcuate fibers. Do you realize then this arcuate fiber, how is it entering the disc? It is entering superiorly and inferiorly. This is the reason why I am going to get cupping first vertically oval. Because it is these fibers which are affected first. They are entering the disc from above and below, so vertically oval. Got it? So now once we know why the cupping of glaucoma is vertically oval first, another important thing to understand, is there any situation where I get this type of cupping? Yes. This can be called physiological cupping. What is this? I have a patient with no signs of any damage, no field effect, normal pressures, but when I look at the cup, the size is more than 0.3. So when it is so, we are calling it physiological cupping, right? So physiological cupping means this patient is not a case of glaucoma, but he has large cups here. Now what is this cupping due to? Generally it is seen in high myopes, where the eye's axial length is longer, there is a stretching of the sclera, there is a large disc, so the cup size is small. So that is what is called physiological cupping. Now how am I going to differentiate? Is it physiological or pathological? A glaucomatous cup is vertically oval, this is not, number one. And very, very important, physiological cupping, you have to know that this is bilaterally symmetrical. The physiological cupping is bilaterally symmetrical. Make another box, write down. Glaucoma is never bilaterally symmetrical. Got it? Either one eye will be affected first than the other, or maybe only one eye is affected, the other is not affected at all. So glaucoma is never bilaterally symmetrical, put it in the box. But physiological cupping can be bilaterally symmetrical. Now you know what is cupping. Now you know what is physiological cupping. We also know why there is a vertical oval cupping first. What is ISNT rule? ISNT rule says that in a normal person, the width of this neuroretinal rim, I, this is the inferior, this one is your S, and any one can be N and T. Okay, suppose this is temporal and this is nasal side, then this becomes N and this becomes, any side can be N and any side can be in this diagram, right? So what is ISNT rule saying? That the width of this rim is most in inferior side, then superior, then nasal, then temporal. Now when there is cupping, there is damage of arcuate fibers. Do you realize? Therefore, what will happen? It starts, most commonly it starts inferiorly. So what will happen here is, the cup is starting, the size of cup has increased. Now the eye is lesser. So glaucoma actually breaks this ISNT rule. Or you can say not followed. That's better option to say. Not follows the ISNT rule. Glaucoma patient is, we don't see the ISNT rule being followed because of the damage, right? So once we know this, what is this situation called when the cup has only occurred inferiorly? Do you realize the outer rim is notched? Rim is the outer space apart from cup. So this stage is called notching of neuroretinal rim. Keep understanding and writing on your diagram itself. We will write it separately as well. And slowly now, when the whole of the cup is involved, now we call it thinning. This stage becomes thinning of neuroretinal rim. Right? And also remember that it is the inferior arcuate fibers which are damaged first. That is why we have shown inferior notching like this. Now, so this is stage is thinning, and then what next happens? The damage is taking place, the nerve fibers are getting damaged. So I discussed this with you all, that lamina cribosa is nothing but sieve-like opening in the sclera. So all the nerve fibers are passing through those openings. When the nerve fibers are damaged, these openings are visible. So this visible opening of lamina cribosa is what is we call, they look at grey spots like this. I can't draw grey here, so I am drawing like this. This is what is laminar dot sign. We will see all the slide, everything will happen, just keep listening. So when these openings become visible, we are calling it laminar dot sign, right? Okay, so these are the main disc changes that we have to learn as the fundus changes. What are the other changes? Let's see further. So now we are clear what is cupping of this? Good. So if we are clear about that, the whole fundus change to make our learning easy, because I want you to learn with me here itself. We can divide it as disc changes. Peripapillary means around the disc, what can be the changes? Right? Vascular blood vessel alignment changes can happen. And of course, retinal nerve fiber layer defects will be seen. Which one is the first? It is always the defects which will start coming, and slowly then cupping. Cupping is only visible when substantial amount of the damage has happened. Even field defects happen after a substantial damage has happened, that we start getting scotomas. Okay? So now, one by one, we come to disc changes. What have we learned in disc changes? CD ratio of more than 0.3 or difference between two eyes of more than 0.2. This is significant. Third, we have just drawn for ourselves notching of the neuroretinal rim, and slowly there will be thinning of neuroretinal rim. What else we learned? The opening of lamina cribosa, that is laminar dot sign. Okay, before I go to the blood vessel change, we will first see the slides, otherwise we will be lost. Let's see the slide. What is this slide showing you? It is explaining you the process of cupping. If this is the optic disc here, so any abnormal pressure that is transmitted from the anterior segment because of increased IOP, what is happening here? This is the optic nerve, right? This one here. So any damage in the retinal ganglion cells and remodeling is affecting the lamina crebosa, and this is leading to cupping of the disc. So it's just giving you a picture of the optic nerve head, right? Okay. We have already learned this so many times. We will next come to the next slide here. This is absolutely clear to you all. We have drawn this together. This is the papillomacular bundle, superior radiating, inferior radiating fibers from the nasal part. Temporal, this is the macula. So superior arcuate fibers and inferior arcuate fibers. Right? So we have learned it is the inferior arcuate fibers where the damage will occur first. Okay. Now let's try to appreciate what is cupping. So this is a normal optic nerve head. You see there is a small pale area. The arrow is already there to show you. This is the cup area and rest is the neuroretinal rim. Right? This is occupied by nerve fibers. Correct? And what is the second showing you? This is your glaucomatous cupping. Why we say glaucomatous? We are looking at the vertical dimension first. Can we see this pale area here? If I ask you what should be the ratio, anything around points more than 0.7, it is more than 0.7. Okay. We come to the next one. So this one again you have already drawn with me. What do we mean by cup area? We generally see from where the blood vessel is bending. We see this bend. Okay. This bend is giving me an idea that where is the cup area, this one. Right. So, and this is the neuroretinal rim outside. These are the main blood vessels. Right? In the whole, this green one and circle is the cup area, right? Now we come to the next one. So here I am looking at the pattern of the what? Blood vessel here, okay? So we see that the blood vessel is coming out here, so there is some notching of neuroretinal rim. Maybe this is little difficult for you to appreciate. Let's see the next one that you can appreciate. So this is the ISNT rule, what it is I explained you. You have already drawn this. I is most, then S, then N, then T. We are just seeing the dimension of the neuroretinal rim and measuring. What is laminar dot sign we talked about? These greyish dots. Can we appreciate these greyish dots here? Right? So these, all these, you know? So this is what is the visible opening of lamina crebosa. Okay. So these are the disc changes. Once we appreciate the disc changes, next, what will be the vascular change? That is the next very important thing. So give the heading. Vascular changes. In the vascular changes, very, very important is nasal shifting of vessels. So, nasal shifting of vessels. When you say nasal shifting of vessels, why is this happening? Right? So, we will understand this. How a particular pattern of damage in the optic nerve is causing cupping and how this cupping is actually changing the alignment of the blood vessel. Let me list it out there. And second very important thing what you will know is about what is bionetting sign. Let's list it out. Bionetting sign, write down, is nothing but double bending of vessels. Double bending of vessels. Right? And third, write down, there can be splinter hemorrhages. In the vascular changes, write down splinter hemorrhage below the disc. What is splinter hemorrhage? These are flame-shaped hemorrhage below the disc. We'll talk in detail about hemorrhages in the retina chapter. Okay, so these are some of the important changes that we have to keep in mind as the vascular changes. Let's have a look. So this is a slide of nasal shifting of vessels, which means, what do you understand? Normally what happens, you can draw this. Here, I am drawing it here only for you all. If you look at the normal eye, the blood vessels will be entering like this. Okay? But when I say nasal shifting, draw it for yourself. We see that it travels, it is entering in such a way that there is this type of traveling, and then this horizontal span that it travels here, these blood vessels. This is what is called nasal shifting. Can we appreciate in this slide here? Please draw these diagrams. So this span, because of the cupping area, see this much is the cup area, and because of that cup area, this is being actually, the blood vessel is almost dragged like this, so that this span that it travels is called nasal shifting. It is generally nasally only, so it is nasal shifting of blood vessel. Okay, why it is happening, we understand from this one. What do you see here in a normal person? Normal person, this is how the central retinal vessel is entering the eye, right? And this is your lamina cribosa. When there is a cupping in the lamina cribosa, so the alignment of central blood vessel will be changed like this. It is almost dragged with that change. I think this is a very simple and self-explanatory diagram in front of you, why you are getting a nasal shifting of vessel. What was the next? Bioknitting. Look here. Let us see what is double bending. So you see, once there's a cup has got actually depth, right? So the blood vessel is going to come out of the cup and then go out of the disc. So there are two bends. One is out of the, see here, you can see this bend. One bend is here. It is already shown in this rectangle, and here also. So one bend is out of the cup, out of the disc. This is what is double bending of vessels. Once it is bending once and then it is coming out of the cup, then it is again coming out of the disc. So this double bending of blood vessels is what is called, are you understanding, is as if it is coming out of a ditch, because this cupping has got depth. So that is what is called double bending of blood vessels, right? Okay, so this was your bioknitting sign. Again, this slide is showing you that it's almost like 0.8 to 0.9 cupping. I can see the shift of the vessel also. I can see a large cup area advanced, right? And I can even see the bending of the blood vessels here and here, right? So this is your little late stage of glaucoma. And this arrow is already showing you this flame-shaped hemorrhage. This is what is called splinter hemorrhage. It is mainly more common, write down, inferotemporally, and particularly seen in patients of normal tension glaucoma. Particularly seen in patients of normal tension glaucoma. Okay, what was the third change? The slide here is showing you. If these two arrows, just pay attention to this. Can you see this area here? Darkened a little bit with the gap. So this is what is retinal nerve fiber layer defects. So it is the nerve fiber layer which is forming the optic disc, right? So this is the nerve fiber layer defect that you are looking at. And this will be the first change. Initially on the fundus, the defects will appear even before a prominent cupping. Okay, so these are generally, we will write it also, see. So here I am seeing the same defect. If I see it through the red free filter, right, it's mainly the green light. We can see it very, very clearly even through the ophthalmoscope. With the red free filter, I can see these defects very nicely. So we'll write it now. Okay, so talking about retinal nerve fiber layer defects, these are slit-shaped or wedge-shaped defects. First point in the nerve fiber layer, and second point, note down, I am not writing here but you can note down, it is best seen in a red free filter, that is the green light, or it could be a diffuse defect that you saw just now in the slide. It was a broad area, all that was a diffuse defect, so you can add that. It can be wedge or slit shape, or it could be a diffuse defect. Chalo, so that was it. What is left? Peripapillary changes. When you talk about peripapillary, so talking about peripapillary change, look at this slide. So there is one area outside the disc. This area is also an area where there is no retinal pigment epithelium layer of the retina, or there is no even the choriocapillaries. What are choriocapillaries? The capillaries of the choroid. So this is called beta zone, and outside the beta zone is another which is called alpha zone. Now your question from in PG entrance, nothing has been asked about alpha and beta, but we will learn one line here. So in peripapillary there can be more prominent beta zone. Beta zone is more associated with glaucoma, number one. And just like optic disc is an absolute scotoma, in any condition, whether you are changing the size, changing the illumination, or however you are testing, you will always get a scotoma because it is corresponding to the optic disc. So that is your blind spot. So what is blind spot? Blind spot is absolute scotoma. So this beta area is also an area of absolute scotoma. Okay. That means in any condition, nothing can be seen. This is absolute scotoma. Alpha is actually mainly due to chorioretinal atrophic areas. These can be chorioretinal. Just draw this on your copy and note this down. I don't want to go in too much detail here. Nothing is asked from this part. Just to cover up the heading, peripapillary. So this is mainly a relative scotoma. So in some situation, I may be able to see something and perceive in my visual field. So this is your relative scotoma. These were the fundus changes. So now once we know what is cupping and what are the different fundus changes in glaucoma, what is the ideal instrument to see all these changes? What is the ideal investigation? Should I do it with a direct ophthalmoscope? Yes, we commonly do that, but it is not ideal. Why? Why direct ophthalmoscope is not an ideal method? Because the examiner is using only one eye. Because the examiner is using only one eye, depth perception is not there. So if they ask you, make a cue here. What is the investigation of choice to see the fundus changes? We are going to answer slit lamp by microscopy. Slit lamp by microscopy. So it means the patient is sitting on the slit lamp. So normally how much do you see from the slit lamp? Slit lamp is mainly the purpose is to see the anterior segment. All the structures along with the lens and 1/3 of the vitreous. Right, this is what is seen. So how can I see the retina? How can I appreciate the fundus changes? I am going to put some lens in front of the patient's eye and I am looking through the lens so that I can visualize this retina and I can appreciate the disc changes in the retina. Got it? This is what a slit lamp, and this time I am using both my eyes. I can appreciate the cupping very nicely. Have a look. So this is a slit lamp by microscopy where you can see the patient. Normally if I don't use this lens, I cannot see the retina, but because I am using a lens and looking through the slit lamp, I will be able to visualize the retina. Okay. So when I am talking about the lenses, right? So when I am talking about the lenses, what are the different lenses I can use for this slit lamp by microscopy? We can divide it into lenses can be either contact or non-contact. Contact means you are putting touch inside the eye, or non-contact. Okay, when I say contact lens, we will learn Goldman 3 mirror. Actually, there are 4 mirrors, not 3, but the name is Goldman 3 mirror contact. One is central also. So, Goldman 3 mirror, we can see through the slit lamp by microscopy, number 1. And then when we talk about the non-contact type, it means as you just saw in the slide, you are keeping the lens in front of the eye and you are looking through it. So non-contact, we will divide it as plus lens, this is convex, or it can be concave. Convex lenses can be plus 60, plus 78 or plus 90, right? And concave, this one is called ruby lens. Know this, there was a question here. So ruby lens is minus 58.6 diopters. Okay? So which is the best? Best is always plus 90. Which gives the best visualization, it is plus 90. Got it? So this was the investigation of choice. What are the other methods of seeing the fundus? So second method, as I said, we can say direct ophthalmoscopy, right? And the third investigation to assess, it could be OCT, optical coherence tomography, right? If the media has to be clear, there shouldn't be any cataract or anything. So we can nicely do this OCT, optical coherence tomography. So optical coherence tomography is generally giving cross-sectional details of the layers of the retina where we are using it maximum. Why am I using it in the glaucoma patient? We will see the thickness of the nerve fiber layer, and lesser thickness will indicate damage. Okay. So what are we assessing? We are assessing the nerve fiber layer thickness. I'll just show you the slide. Okay. And it is very useful in order to see or screen any glaucoma suspect or early cases. So very useful for What is glaucoma suspect or any early case of glaucoma? So glaucoma suspect, it is a very serious entity in the disease of glaucoma. Reason being, suppose you are coming to my OPD, I am examining and I say, okay, no, there is no glaucoma. At present, we are not worried. Suppose there is some doubtful, my increase of the IOP, there is some doubtful picture in the fundus, doubtful visual field changes, but still it is not coming under the criteria of any serious damage. So you don't have glaucoma. I am not going to start your treatment. But what I am going to advise you, please don't be so much assured. According to what I see in your eye, I may call you after 1 year, again I am going to check. If everything is fine, actually this should be checked for another 2 more years. And if then also everything is fine, then we say, okay, you don't have glaucoma, don't worry. You understand how important this is? Because you never know. And glaucoma is a irreversible damage. It's a leading cause of blindness in developed countries also. So I cannot just rest assure the patient and suppose he starts developing the damage, there is a progression, then what? So that stage where I am doubtful about whether you have or not, because of some doubtful picture, right? This is glaucoma suspect. So actually glaucoma suspect has a definite and is a definite entity, right? Understood? So it's very simple to understand. My IOP is increased more than 21. Plus minus fundus picture. You're not totally clear, okay, there is nothing. Maybe your CD ratio or difference is coming more than 0.2 or your CD ratio is around 0.5. Okay, there is a query. Or the field changes are again not clear cut. There's some query, some plus minus visual field effects. Generally, I have seen in the patients that generally field effects are not there. Any prominent serious. That is why we don't do much about it. We just call the patient again. And of course, positive family history. If these criteria are there, plus minus visual field effect, plus minus means you have a confusing picture. We cannot say you have glaucoma, but we cannot also not say that you don't have. This is glaucoma suspect. So it's an official definition. Who is a glaucoma suspect and how I should be calling that patient on follow-up on a yearly basis. Got it? Okay. Let's just come back to OCT. So we said that OCT will see the thickness of the optic nerve. Okay, let us see the slide first here. These are the lenses I can use for slit lamp bimicroscopy. So 20D is mainly used in indirect ophthalmoscopy, and for slit lamp bimicroscopy we go for either plus 90 or plus 70, right? Okay, then we talk about, this is a slide showing you the OCT where I am seeing the thickness of the optic disc. So a very quick thing, when we get this chart in our hand, right? See, everything is mentioned here and it is also shown in a graphical manner. Green is within normal limit, red means you have problem, you have glaucoma, and what is yellow, that is a borderline, right? The yellow chart, if this black line is the patient's data. So if he is totally in green, this is within normal limits, right? And if here it is coming to yellow, it is borderline, and red is outside the limit, right? So if you look at if the details of the thickness, this is depicted here. Can we see this? So this is all the thickness in microns, right? Okay. So when there is a thinning of the nerve fiber layer, we compare with the same age normal person and then we record it. Okay. This one is another slide, again showing the data of nerve fiber layer. Just be familiar with how an OCT for glaucoma looks like. We have a graphical representation as I showed you there. Again here also you can see this. You can see here the red means it is low. So this is how we go for it. So very quickly we see this only. It is measuring the nerve fiber layer thickness. Right? What are the other investigations? Apart from OCT, that was number 3. Number 4 we will also note down is, what is SLO? This is confocal scanning laser ophthalmoscopy. So scanning laser ophthalmoscopy. That could also be one of the investigation to assess the nerve fiber layer. Okay. So just now these I just want you to be familiar with the names, nothing more. Right? And second is SLP, which is scanning laser polarimetry. SLP is scanning laser polarimetry. Done? These are the different, but you know, commonest and the investigation of choice, it is always slit lamp by microscopy. And yes, very routinely we do the OCT as well. Now, you know, after a level of damage in the nerve fiber layer, maybe the thickness around normal limits is anything around 100, 115 or less, ranging something like this. But suppose the thinning has occurred so much that it is going around 40, 45 or 50. Below that, even if there is a damage, OCT cannot show. Just keep that in mind. That is called floor effect. So floor effect in OCT means now below the level of 45 to 50 microns thickness, it is not going to show. So you cannot know the progressive damage. So let us talk about visual field effects now. What is a visual field? Peripheral vision, right? You are looking at me, but you are aware of your surroundings, your table, where you are studying, and whatever things around you, you are aware of that, right? So this is your visual field. That is peripheral vision. I'm just simplifying it. I'll give you an exact definition as well, but as of now, just understand what do you mean by it. Once you know what is a visual field, we next talk about is, there are two more terms you have to be very, very clear about. What is isopter and what is scotoma, right? So this is how we are checking. So we are checking the your light sensitivity, differential light sensitivity at different points, right? So this three-dimensional representation of differential light sensitivity is called visual field. If I want to write it for you, we will say it is three-dimensional. I'm writing, please write along. It is three-dimensional representation of differential light sensitivity, right? Differential light sensitivity means against a particular background, against a particular luminance, how much I should increase the luminance of the target so that it is visible to the patient. It's a differential light sensitivity, okay? So this is what it means. Okay. Once you know this, what is a visual field? Exam question here. What is the extent of your visual field? So visual field extent, if we have to learn, let us learn it like this. Temporally, it is 90 degree or 100 degree, both are correct. Inferiorly, it is 70 degree. Nasally, 60 degree. And superiorly, it is, some books say 60, some 50, let's take it 50 degrees, okay? So we have to keep in mind that where is your visual field, extent of the visual field maximum? Temporally. And where is it minimum? Superiorly. In your right eye or left eye? Any eye, isn't it? It doesn't depend upon right or left. So any eye we are talking about, we are saying that the field is maximum temporally and field is minimum superiorly. I hope you remember what I discussed in my initial lecture, that when you're talking about the visual field, the patient is fixing a central target. Suppose this is the central target the patient is looking at. Then I bring another target from the periphery. Wherever he is first aware of, that is the outermost extent of his field. Now we keep moving it, moving it, moving it. So at one point he can tell you, no, I cannot see. Mark that point. Keep moving. Yes, I can see. Mark that point. So that area where he was not able to perceive anything, that area in the field, in his visual field, that is what is called scotoma, isn't it? So what is a scotoma? It is area of reduced sensitivity, right? Or total absence, but surrounded by normal seeing area, isn't it? So we can say scotoma, if I have to define scotoma, we will say scotoma is area of reduced, or if I make life simple for you, area in the visual field where the patient cannot see, right? So it's an area in the visual field, or you can say it's an area of decreased sensitivity, reduced or decreased sensitivity, or decreased vision, or even total loss of vision, but surrounded by normal seeing area. That is very important. Surrounded by, so area where patient cannot see, surrounded by a normal area. This is what is scotoma. Normal seeing area is scotoma. I think this is absolutely clear now. Now, when I have to take the visual field, I have to check the whole retina. So I should be checking all the points, right? So the different axes on which I am checking the field, right? So those planes, that is what is we call isopters. So what are isopters? To understand, if I join the points of same light sensitivity, that line that I draw is called an isopter. I'll just show you the slide. Write down, what is an isopter? If we ask you, you'll say it's area of same sensitivity, okay, to the stimulus, or it is a line which is connecting the points of same sensitivity. It is represented in two-dimensional form. It is a line connecting the area of same sensitivity. Okay, all of you. If I'm going to take the visual field of all of you, I'm again going to test it in different axes, right? So suppose on different isopters I'm testing your visual field. Now, do you realize that each and every one of you at one area will say, okay, I cannot see in each eye, right? So every one of us have one area in the visual field definitely where we cannot see, which is corresponding to, you all know, it is corresponding to the optic disc, and this is what is called blind spot, correct? So what is blind spot? Blind spot is your physiological scotoma. It is nothing corresponding to optic disc, it is our physiological scotoma. So now you know what is a visual field, how and what are different isopters mean. We also know what is a scotoma and what is a physiological scotoma. Now, what is the normal extent is your exam question. I hope you have made a Q there. Another thing they ask you is, where is the blind spot located? Put a Q, write down, blind spot is located between 10 to 20 degree isopters. What is all about isopters? Let's have a look. Look at this slide. So if we'll just understand this slide, this is a simple representation, vertical and horizontal meridian, right? The blind spot is shown and central fixation. So this is how you are testing the visual field, where you are asking the patient to look at the central fixation point, which is here. This is his macular foveal area, right? Now the patient is fixing here, but you are testing the light sensor. So directly he has to look only at the center, and now you present with the different stimulus to check his light sensitivity at different points of the field, correct? And we all know every one of us will have this scotoma corresponding to optic disc, which is blind spot. Okay, so 2-3 things I want you to understand here. Which eye is this? If I represent it like this, please remember that the projection of the retina is always in straight line but opposite to the field, right? So what I am trying to say, if superior retina has a problem, you get inferior field effect. Inferior, superior field effect. So field is always opposite of the anatomical defect. Okay, can we remember this? Why? Because understand, if you look at my right eye, my right temporal part is not giving the vision here, it is giving the vision here. Projection of retina is crossed. So why this is happening? Why the field is opposite to anatomy? Because the projection, light travels in a straight line. So projection of retina generally is always crossed, right? So if the temporal retina has problem, I will get a nasal field effect. Nasal has problem, I get a temporal field. I hope you got it. Or then if you have understood this part, so if superior fibers are gone in the optic nerve lesion also, so superior fibers are gone or inferior fibers are gone, accordingly I will get, if superior fibers are gone, I am getting inferior defect. We will talk more about this in your neuroophthalmology. At present, so you understand this, if this is the blind spot, normally optic disc is nasal to the macula. Now in blind spot, it will be just the opposite. So this becomes the temporal part of your visual field, which you will tell, and this is the nasal part, right? So please keep that in mind. Disc is nasally placed, therefore blind spot will be opposite, that is temporally placed in the field. If you don't understand this, you all are then totally confused in neuro-ophtha chapter, in glaucoma chapter. So please, this is the basic to understand. Okay, once you know this, then which eye have we represented here? So this is temporal, so this becomes our So you have to understand this way, that whenever we depict a field, right? So whenever you are depicting a field, it is as if the patient is beside you. So this will be, if this is the field and this is the temporal, we are talking about left eye. So this becomes your left eye. Okay, so this is the left eye visual field which I am talking about, isn't it? Why we are saying so? Because field is opposite to anatomy, right? Hope you are clear with this. Now, once you know this, then also understand and learn here. When we say blind spot is a scotoma, what type of scotoma is this? It's a absolute scotoma. Absolute means even by changing the size of the target, illumination, any condition, it is always a scotoma. In this area, nothing can be perceived. Then it is called absolute scotoma. Then there are two terms, is it negative or positive scotoma? So please understand, positive scotoma means that there is some black patch in front of the eye, right? And the vision is obscure. Whereas negative means it's a hollow space. So here when you say blind spot, it is a negative scotoma. So it's an absolute negative scotoma, correct? We come to the next important point. So once we know and how to read the visual field chart first, so which is temporal, which is nasal, that is very important to understand, right? Which eye it is. And so once we know this, now we talk about, let's see the next slide. We were talking about isopters. So this is for you. How, I think this one is a better and clearer one. Yeah, let's see this one. So if you look here, this is the isopter where same light sensitivity points are joined in a line, right? So we represent it like this, as you see below, 10 degree, 20 degree, 30 degree isopters, right? So these are the different planes in which I will test the visual field. Got it? So let's have a look what we are trying to see here. The sensitivity is maximum where the patient is fixing, that is at the foveal area, isn't it? And it is decreasing, the extent of visual field is also being shown here, right? So it is around 60 degree nasally, right? So this is seen, as you see here, this is 60 degree nasally, right? And we'll learn here inferiorly it is 70. So there can be a little variation in different sources, but this is what we will learn and answer in the exam. And can you see the blind spot? It is between the 10 to 20 degree isopter. This is 10 and 20 degree isopter. The sensitivity is being shown, how it is maximum at the fovea and how it keeps decreasing like this. Nasally it drops very acutely and temporally drops slowly, right? So now you're very clear what are isopters, and the previous was also the same, it's a little larger, is the same thing that is being depicted here. And if we look at these are the different isopters. We have already made a meridian and understood this is the vertical and horizontal meridian. Okay, if we have understood what are isopters, we now will talk about visual field defects in primary open angle glaucoma. Okay, so all of you write like this, visual field defects in primary open angle glaucoma. So we will divide it into early and late defects. We divide it into early defects and late defects. Keep a space here, I am going to draw in between. So let us draw the visual field chart. So suppose we draw a visual field chart. So how are you going to draw it? Make a circle, make these two meridians, vertical and horizontal, right? So this is 0 or 180, whatever you want to say, and this is 90 degree, right? And these are the different isopters. So I'm just going to make a few. We can either make the multiple lines or we can just stop, make this much only. It will be more clearer. Now all of you, if this is the blind spot, suppose this is the blind spot. So here is the blind spot, between 10 to 20 degree comes something like this. So this we will make a blind spot. Please draw along with me, then you will understand the field effects very easily. So if this is the blind spot, what did we learn in the fundus stages? That the first, it is the inferior arcuate fibers which are affected, which is inferotemporal. That means our first field effect just opposite to the anatomy, superonasal, right? This area where you are getting the first field effect, what do you call this? So we are getting superonasal paracentral scotomas. And this area, I should have to mention there also, maybe we missed, but we can now understand, if the first fibers associated are the arcuate fibers, Do you understand and realize arcuate fibers are giving vision to a particular area in the visual field? So the first scotoma will always be in that area contributed by that arcuate fiber, as I have explained you here. If inferior temporal fiber is gone, this will be scotoma, and this area where you get the first visual field effect, which is corresponding to arcuate fibers, is what is called Jerum's area. Can we make a box and write this? All of you, let's first understand what is Jerum's area. So Jerum's area likho. Jerum's area is area in the visual field, where first scotoma appears, isn't it? And this first scotoma which appears is corresponding to arcuate fibers. Please note it down. Very, very important, repeated question. Which is the first visual field effect? So earliest field effect is which one? This one. So this is a repeated question. Earliest field effect, central or paracentral scotomas in Jerum's area. I think you got this. Okay, so once we know this, slowly what happens, the progress of the pattern of the damage is very typical in glaucoma. So slowly, next thing that is going to happen is, one of the scotomas is going to start, when this is paracentral scotomas, the damage is increasing and it is merging with the blind spot. So this is sickle shape, which we call sedal scotoma. This is another early change, sedal scotoma. Write down, this is your sickle shaped scotoma. And this sickle shaped scotoma, where it is paracentral joining the blind spot. This is your sickle shaped scotoma. And what will be the next? You will know what next will happen slowly. Now this is going to extend and involve this whole field. Right? So, okay. One more interesting thing, sometime you should know this as well. If this is the blind spot which is temporal, I think this everybody is clear, this will be temporal side of the field and this is the nasal side of the field, isn't it? So, you may get at the central, some changes initially on the nasal field. I'll show you it in the Humphrey chart, which is called nasal step. Okay. So, what is a nasal step? Any scotoma on the nasal side, okay, which is appearing, is called nasal step. Slowly after that, you are getting the one that I draw for you. Here is your arcuate scotoma. So this arcuate scotoma is crossing the midline vertically, coming here, and it is all superiorly, then it is called arcuate scotoma. So this comes in the late different. So one we will write here, arcuate. When the inferior field is also involved, now what happens is something like this, right? And this is what is called double arcuate scotoma. When the inferior field is involved, it is double arcuate scotoma. So slowly the whole field can go according to whatever nerve damage is happening. It will extend to whole of the field, right? But just before blindness, what we are left with is central island of vision. So I'm making it as dot dot. This is island of vision, central island of vision, and a small temporal island of vision. So just before blindness, we are left with what? This is island of vision. This is not scotoma. Central and temporal island of vision. Okay. So next question for you. First question was, which is the earliest field effect? It is paracentral scotoma in Jerum's area. Second, it forms sedal scotoma. Then it can appear as, we will write an early change only. Let me write it here. In the early change only, you can say there can be nasal step. I am not saying Raynaud's nasal, I am just saying it could be a nasal step, and then it can be in late changes arcuate scotoma and double arcuate, which we have written already. And just before the blindness, what we are saying, that just before the blindness, central and temporal island of vision is left behind. What is the next question? Which island of vision stays till last? We will answer, make a Q and write here. Which island of vision stays till last? We will say it is temporal island of vision. Please keep in mind it is the temporal angle of vision which will stay till last. Okay, so when you say this superior arcuate, one more thing, superior arcuate scotoma can also be known as Jerem scotoma. Okay, the superior arcuate scotoma which you have learned here, superior, this is the arcuate scotoma, we can also call it Jerem's scotoma. Right, so when this superior and inferior, when the two scotomas are meeting and there is a double arcuate scotoma here, we can also call it, double arcuate is also called ring scotoma. So there are two more terms here. When it is the superior arcuate is called Jerem scotoma, and when it is all around we can call it as double arcuate or ring scotoma. So keep that in mind. Where else do we learn ring scotoma? We learn this in retinitis pigmentosa. We will talk about it in the retina chapter. Okay, so let us have a look at the slide here. Look at this. What we see here, this is the nasal temporal it is showing, right? So what are they? It's just showing you the different, it's not given in sequence, it's showing you the different types of scotoma. So this one becomes your arcuate, or we call it superior arcuate or arcuate in the Jerem's area, right? That's why it's sometimes also called Jerem's scotoma, right? Then this is your, look at the other one. Paracentral scotoma, this time it is shown here superiorly, but please remember the first will always be in supero-nasal part, right? Then sickle-shaped sedal when it is joining the blind spot, we know this, right? Okay, then again this is a repetition about the superior. We also talk about here is, so when there is a ring scotoma like this more at the, as it is showing you here, this can lead to a gap. Can we see this gap here, especially at the little outer field? Can we see this? Why? Because these fibers are not abutting exactly. There is a small gap here. This is what is called Raynaud's nasal step. Okay, so this is what is Raynaud's. So nasal step was just scotoma in the nasal part of your field, which can appear in the early part as well, or it may appear a little later. So actually it's very difficult to put it into early defects or late defects. Mainly early defects definitely are paracentral and central scotoma in Jerem's area. Early defect is sedal scotoma, right? Rest you can even consider in the late defects only. Then we talk about, as I said, what is left behind at the last. It is showing here the temporal island of vision. So if you are just going to make the diagram by your own hand, it will be more simple for you to understand and revise. Okay, right. So how do you, what is the method of seeing the visual field defects known as? Achha, before that, many of you have a confusion about this term bearing of blind spot or isopter contraction. So I would like to clarify this. If the question is first visual field change, so which has not been asked yet, but if they say so, then I can talk about isopter contraction. What do you mean by that? The outer extent of the visual field is little lesser. So please understand that this field effect, that is isopter contraction, is not charted in the usual way where we are doing a standard perimetry with a definite 5 mm target size, right, with a particular illumination. Here we have some very small target size, particular pupil size, and a very definite illumination to chart an isopter contraction. So what is the common mistake which students do is, first visual field effect, ma'am, is it isopter contraction? Many places it is written isopter contraction. Please don't answer that. Okay, at this stage patient is not even aware of any problem. So the first visual field defect anyway, when you chart it, can be, is first is always Jerem's area, Jerem's area, Jerem's area. Don't forget that. Okay? So you will always say central or paracentral scotoma in the Jerem's area. So here, if I draw it for you to explain you, if this was the whole visual field chart and this is your blind spot, the extent of this field is isopter contraction, and it is because not including the blind spot, it is something drawn like this. You can draw it on your own. So the extent of visual field is little isopter is contracted but not involving the blind spot. Hence it is also called bearing of blind spot. So we will not go too much into details. Apart from this, what are the 2-3 points I told you? Usual conditions are not there to chart for the perimetry. It is, you can consider it as a first visual field change but not a first visual field defect. Okay, keep in mind. I don't think this should be asked now, but if asked, you should be familiar You should not think, okay, ये तो बताया ही नहीं, right? So this is what is isopter contraction. Again, it will be considered an, of course, the early field defect or early field change, not defect. Huh? Correct? Achha. Once you know this, we were talking about the method of visual field charting is called perimetry, right? So when you say perimetry, perimetry can be divided as kinetic and static. We all know the one that I have given you in the example where I am moving the target in the different planes. This is way of kinetic, right? And what is static? When the patient, so in static, it is multiple stimuli are shown and there is no movement of this stimulus, okay? So that is what is called static. Static is the computerized method or automated. We also call it automated perimetry. Computerized method or automated perimetry. And both kinetic and static can be further divided as central, peripheral, central, peripheral. Central field means, central field charting means what? Central 30 degree of charting is central field charting and the rest is the peripheral field charting. Got it? So this is a very simple way of understanding. Now coming to one by one, when you say kinetic can be of, let's describe kinetic. Central and peripheral is one way of saying it. What are the methods of doing a kinetic perimetry? So kinetic perimetry can be done by, definitely by confrontation test to have a quick idea if there is any problem. Number one. Let's list it out, then we will take one by one. And of course, the second very important is your Goldman perimetry, right? Goldman perimetry. Particularly only for the central vision, we can all, so this will check everything, Goldman, both peripheral and central. But if you talk about central vision, one that was used before was Jerem screen. These days only 1 and 2 are more commonly used. But you should know what is Jerem screen. It is again a screen, just it's a black screen in front of you 2 meters away. One eye closed, the patient is given one target and again the target is moved from periphery to the central and the field is charted. So all these things of course is all subjective tests where we need a lot of attention from the patient, right? So this is your Jerem screen. Okay. So this, and earlier just that this is the old name, you should also know this Leicester's perimeter. Just be familiar with the name. This was used for the peripheral field charting. These are all kinetic perimetry, right? And of course, when you say static, static is automated, computerized. What are the two softwares for the static perimetry? Mainly we use Humphrey. So we call it Humphrey Field Analyzer, right? And second you will say, just know the name of the software and that is Octopus. Humphrey Field Analyzer and Octopus. Let's have a look at these different slides now. So this one is your confrontation test, right? So what is happening? The patient is in front of me and both the eyes should be in line, right? So my right eye, patient's left eye, one eye closed. And again, I am doing the same test. If I am able to perceive the object, is the patient able to do that or not? So doctor is comparing the field of the patient with his own field and trying to know with a quick idea of is there any problem or not. This is what is confrontation test. Okay? So again, I will be doing in all directions. If I have to test the whole retina, I should be doing in all directions. Then we talk about this one is what you are looking at is called Goldman perimeter. Again, it is the same principle with the kinetic perimetry that I have been describing to you. We always test one at a time, one eye at a time. So this is your Goldman, this is your confrontation, and this is what is automated. So what happens? This is the computer screen here. I think I have one more. Yeah. So this computer screen in automated perimetry will tell me whether the patient is fixing properly, what are the false positive, what are the false negative, everything will be there. This is we keep the chin of the patient here, he has a button in the hand, right? One eye closed, now he is focusing on the central white target and then there is a bowl shaped screen here, like a bowl. And there are multiple white lights there, right? So whenever he feels any light is on, he has to just press the button. Though he has to keep looking straight only, but whenever there is any light is on, he will press the button. So this is how we are testing his light sensitivity against a particular background luminance. Got it? So what is in a particular background luminance, again I am explaining you, how much luminance I have to increase in that target so that the patient can see that. That is his differential light sensitivity, right? So whenever there is a problem in the optic nerve, whenever there is a damage of the optic nerve, naturally this light sensitivity will be less. And if it is in a pattern of a glaucomatous damage, it will confirm glaucoma. So this is about your automated perimetry or Humphrey field analyzer that you're looking at. Okay? Okay. So once we know this, then this is what is Jerem screen. I was describing you how from 2 meters now how this examiner is taking the target from a periphery to the center, and the patient has to respond accordingly. He has to fix here only. Okay? This is mainly for the central vision, which was done. Most commonly now what we do is through Goldman. If I have to do a kinetic, it is Goldman, and a quick one is confrontation. Okay, but most reliable of course is automated, but not everything computerized is reliable. Keep that in mind. When you go for an auto refractometry where you are seeing the number of your eye, refractive status of your eye, this is not an exact number. It's just giving you some idea. Exact is what patient says after subjective or the test that is done. Okay, but here this computerized perimetry, yes, this is very accurate. Okay, so we'll learn little more about Humphrey field analyzer. I told you it's a static perimetry, correct? So very simply I will explain you. I am sitting in front of a bowl-like screen, one eye closed. I am looking at a particular target size. So when you talk about the Humphrey field analyzer, few things that I have to know. It's very interesting. So let's not panic, it's very, very interesting. Let's try to understand what it is. So there is a particular stimulus size. Now the stimulus size has been standardized according to, so at the target he is fixing at the central fixation point, and there are different stimulus that is given. The stimulus size in a Humphrey field analyzer is mainly in Roman numbers 1 to 5. Okay, and just keep in mind if this is the size of a blind spot. Okay, if this is the blind spot suppose, then any size could be 1, 2, 3, 4, 5 can be from 1, then 2, 3, 4 and little bigger is 4 and this is 5. So do you realize something? How small the target size must be that we are comparing it with a blind spot like this. This whole thing is blind spot, and accordingly this can be 1, 2, 3, 4 and 5. These are the 5 ways we give the stimulus size. Just have this idea. Background luminance ki again you have to find out. Generally the background, and so how do you just measure the luminance? Apostolbs, right? So it is generally 31.5 apostolbs. So this is another important thing about the background luminance. We are talking about background luminance is mainly 31.5 apostolbs. Okay. Once we know this, now at any particular point, how do you describe the light sensitivity, whether the patient is able to see or not see against this background luminance, right? So that is what is called, we describe the sensitivity in decibels. So sensitivity will be described in decibels, right? Do you realize something here? More sensitivity means even in a very less luminance I will be able to catch something. If the sensitivity at one point in my eye is very good, then I can catch even a very faint light against this background luminance. And if my sensitivity is not good, then I have to have a very bright light to perceive it. Therefore, sensitivity is what? It is inversely proportional to luminance, isn't it? The lighter luminance I am able to catch, higher is my sensitivity. I hope you got this. So these are some basic things first to understand. So this particular stimulus size is shown at a particular background luminance, and now I am checking the sensitivity of the patient. Do you realize what will be the sensitivity at a blind spot? 0. It's an absolute scotoma. And what should be the sensitivity at the macula? What about here? At the fovea, it is maximum up to 39 to 40 decibels. Whereas for the blind spot, of course this will be 0 dibs. Right? So just keep this in mind, just a basic thing that we have to know. So what is happening? This is what this computer is finally charting for us. Okay? So how does this chart look like and what are the things I have to see? Suppose the patient is not looking at the central, and how do we make sure that he is looking at the central target or not looking at the, generally there can be fixation trackers in the machine, which will tell me that, okay, where is the fixation. Fixation losses are also mentioned in the chart. And what false positive, false, suppose you are very, very eager to respond. Sometimes even if you are not seeing the light, you have pressed the button. So this is not a correct value, isn't it? And sometimes you may miss, so it may be just due to absent-mindedness, you are lost, you are tired, and you are missing the points. So there can be a lot of causes of false positive and false negative. Everything depends on the patient's alertness and response. Got it? So let's see the chart. Let's try to understand what this chart of automated perimetry is all about. So very, very important is to understand. So see, what are the things given here? Let's see in this chart. Apart from fixation, target has to be central, or sometimes if the patient has got central scotomas, right, then you can give some fixed diamond of central points, with the multiple points which are called fixation diamonds. So instead of having a central point, there are just below the center point, we have diamond shape 4 5 points, 4 points, right? So this is one important thing. And secondly, what is the chart showing you is the patient's name. Age is very important to mention, because everything we are comparing with the age, what is the normal in that age. So age is a very important parameter to be notified, right? So we generally ask the birth date, and hope it is mentioned correctly. Then we have to see about the false positive and false negative. Can you see this is what is called reliability indices. So reliability indices में what is the fixation losses कितने थे, how many times the patient has removed his eye from the center, then what are the false positive, what are the false negative, what was the test duration, okay, and this is the decibels of your fovea which has been notified. Okay, this much decibels the fovea is, we can note it, right, as in this case. So any reliability index is false positive or false negative, it becomes more than 33%. If you want to note down, note down. If it is more than 33%, the test is not reliable. Please keep in mind. Okay? I'll take it little quickly. Reason being, lot of details have not yet been asked in your PG entrance. But know the basics. Okay? Second thing what we see is, what is given here is background luminance, tumulus size 3. Now you know what is tumulus size and what is the luminance, right? It is generally 31.5. Now strategies I'll just discuss with you. Okay, what are the different testing patterns and what are the different algorithms. Just shortly I will talk about that. Let's first understand this chart. It is very, very interesting. In this case, what they are showing you, numerical sensitivity plot. So there are 6 graphs. If you see in any chart, in one paper for one eye, there are 6 patterns given, 6 graphs. You know, what are they telling you? First is giving you the absolute threshold value, the decibels. So in numerical value, how many decibels is what? So you will know the sensitivity, and then a gray scale of this, okay, a quick gray scale. So in this case, it seems to be normal. This is the blind spot, right? Okay, so we are looking at the right eye. Now this one, then what is the next thing? Next thing is numerical total deviation map. Means now this one is comparison with age related normal. So in this age, what should be the normal pattern and what is the patient's pattern? So if anything is given in minus here, it means it is lower than the normal. 0 can be considered equal to the normal and plus can be better than the normal. Okay. Then this though you have taken care of the age here in this chart. What about the next one? The next is your deviation map, which is pattern deviation, which means suppose this patient has cataract. Even then there will be decreased sensitivity overall. So we are now taking care of all the factors which could be the cause of decreased sensitivity and then trying to plot the graph. So that is pattern deviation. This is total deviation, compare with the age. This is pattern deviation where we are trying to find out. So this is another thing. And then comes the third. Third is generally the probability. Okay, it's a probability chart of total deviation, probability chart of pattern deviation. Everybody knows from the statistics knowledge that any p-value of less than 0.5 is very, very significant, right? So this is the mark of less than 0.5. So you know, very quickly if I have to look at the chart, I don't have to see so much in detail. You know what we do when the patient comes? Very, very important. Reliability I'll check first. I'll check the age. I'll check all these things. It is the correct patient. He's the correct patient. Quickly I'm going to look at the gray map. Great. When the gray map, I look here, grayscale map, okay, I have got very quick idea. I don't have to look even to the decibels. Straight away I go to the probability map. And here also I will like to see the pattern deviation. And whatever I see in the pattern deviation is the final go. Here I see that it is absolutely normal. Okay. So this is how we are going to see. What are then these global indices? What are these mentioned here? So glaucoma hemifield means I am comparing it, the superior and inferior field is being compared. Okay. And of course visual field index. So if I take a normal person as 100%, what is the visual field of this patient compared to the normal? If the normal is 100%, that is what is visual field index, correct? Then mean deviation and pattern deviation. Mean deviation will tell you the overall deviation from the normal, and pattern deviation is going to tell us about the localized defects, right? So mainly if we know the mean deviation and pattern deviation is also very important in follow-ups of the same patient. Okay, I told you, na, the glaucoma suspect, we have to keep looking yearly or 6 monthly according to the patient. So we have to go for the blood, this field test, right? And we have to see these values. So just giving you a general idea, what is a Humphrey field chart looking like, correct? Now, once we know this, let's quickly see what are the different patterns I can look at. Now, this is again, both eyes are given here, right and left. As you can see, this is the blind spot here, this is the blind spot here. So the same thing you have to understand. Numerical plot, deviation plot of both eyes, and then the probability chart of both the deviations, total deviation and pattern deviation. So I ask you to comment on the chart. Please look at the grayscale, please look at the pattern probability, and you can answer me. But of course, before that, look at the reliability indices. Okay, that is very important. Right. So another thing that you see in the chart, look at the parameters. It is saying central 24-2 threshold test. So now this is the another one important thing that we have to understand. So let's understand this way. When you talk about testing patterns, right, in this automated perimetry, the testing patterns can be of 3 types. The testing patterns can be 30-2, it can be 24-2, or sometimes in advanced cases of glaucoma, it will be more central field I want to check, that is near the macula, that is around 10-2. Okay, so this means what? It means I am checking the central 30 degree of the field, here I am checking only central 24 degree of the field, here I am checking central 10 degree of the field. Simple. That's where the glaucoma changes are expected, in the central field, therefore I am focused there. Now, what is -2 every time? -2 means that my testing points are not on the vertical and horizontal meridian. So what happens? If it is not, it will not cause any confusion, in the sense that I can actually comment on the hemifield status, where the superior field and the inferior field, I can divide it cleanly and discuss and present the test results. Okay. So that is why just remember -2 means that the testing points are not on vertical and horizontal meridian. Or raphe or meridian, whatever you want to say. Now you got it, what was written there, 24-2. Okay. So now next thing was about threshold tests. So there are different algorithms or ways of testing these points, right? So the different points that I am testing by presenting the stimulus. So what are the different testing algorithms? Give the heading, all of you, testing algorithms. Again, I don't want to go too much in detail, right? Just an idea, because this is the latest thing and we are more into preparing some surprise questions from here. Otherwise, till now, nothing, the details have not been asked. So we will just quickly name it. First is threshold testing. Threshold perimetry means what? I am giving a stimulus of particular intensity, right? Luminance, right? And we see that in that luminance, at least 50% of the time the patient should be able to respond. So how you do is, you first give a very high intensity of luminance. Then when you see, okay, yes, he is responding, now start decreasing it at an interval of maybe first 4 decibels come karo, then again less, or then at the interval of 2 And then every point you are titrating like this to find out the exact decibel for that point. You got me? So first I am giving a higher intensity, then I am lowering it, going back, and then which is the best one. So this is taking a lot of time, but yes, this is one of the most reliable thing to do is threshold perimetry. Do we do it now? No. It's too time taking. Sometimes we have to monitor glaucoma. The main role is in monitoring glaucoma, of course. You know, patients, if they are old patients, it's very difficult for them to do it with to maintain that attention span as well. It's not easy. Then second is your supra threshold. Next algorithm is supra threshold, right? What you are doing here is you have quickly compared it. You are giving it above the normal threshold levels for that age, okay, of population. So I have a data for that particular age, and then according to that I am giving first a supra threshold, means a little above the testing stimulus is above the normal threshold limit, and I am quickly trying to see, okay, I am slightly above the threshold normal limit, and this is majority population is showing this normal limit. Now is this patient even little above it or not? Okay, he is little above it. Okay, fine. That is mainly quickly for screening. So supra threshold perimetry, but it has to be age matched. That is very important. Okay, so this is mainly for quick screening. Otherwise, if I have to really do anything in detail, it should be a threshold method. And then comes the faster algorithms. When time is less or attention span is less, we go for the fast algorithms, right? Fast algorithms, what are the things? What are the names? Let us learn that. First, in fast algorithm, we will know is CETA standard. What is this written everywhere? CETA standard. Huh? So CETA stands for Swedish Interactive Threshold Algorithm. So write down, it is standing for, just you should know them, Swedish Interactive Threshold Algorithm. Okay. When I say CETA standard, I am only checking 4 points at the threshold level. Threshold perimetry, threshold points are only, values are only tested at the 4 points, full values, threshold values, right? And rest with the database of normal and the database of glaucoma patients, I am trying to estimate the threshold value of this patient. Don't go into many details, know the name. Second, know the name is CETA fast. Just remember, I have a database of normal, I have a database of glaucomatous patients, and then I am quickly trying to estimate the threshold value for you. Okay, so that is CETA standard. Now, when you say CETA fast, it is little even faster than the CETA standard. I don't want you to know too much details, just know the names. Third is fast pack. Know the name fast pack. And and then fourth, just know the name TOP. What is TOP? Is tendency oriental perimetry. I would only want you to be familiar with the names, nothing else. Okay, that's it. Okay, what about some higher sensitivity visual fields? So I think I told you, no, that has to be some substantial loss for me to catch hold of it. So even in a visual field testing where we are testing, the nerve fibers layer should be substantially, there should be some loss. Then only it comes in the field as a defect. So to catch some early changes, we have some high sensitivity field modalities. So we will again just know the names. What are the high sensitivity field modalities? Right? We will know two names. One is SWAP. So that was SAP. SAP is Standard Automated Perimetry, which you have just learned with me previously, whatever names you knew. Threshold perimetry, supra threshold, CETA, CETA fast pack, and so on. Now we are talking about higher sensitivity field modalities, means this time I am trying to catch any specific group of cells, ganglion cells, and testing it. Okay, so if you talk about SWAP, it is for mainly the short wave automated perimetry. It stands for short wave automated perimetry. AP is automated perimetry. Now this time what is happening? My stimulus is blue and my background is yellow. So it's a blue-yellow. So stimulus is blue and background is yellow. Okay, so it will mainly be catching hold of blue sensitive cells or the coniocellular cells. We'll talk again in neuro-ophthalmology. So because the cataract is actually decreasing sensitivity to blue light, na? It absorbs the blue. So that is the reason if a patient has cataract, this test doesn't hold much reliability. Okay. Then we have another name, just know the name again, I'm telling you, FDT. Okay, this is frequency doubling test. So write down, this is frequency doubling test. It is specifically catching hold of magnocellular layer and larger ganglion cells. That is, these are magnocellular. Let's see some few more charts here. Once we have understood now what is this? This test was threshold test and this is central 24-2, 24 degree of the field has been tested. Okay, let's see a few charts here. So this one was explained. It's a normal chart of both eyes. What is this you see? Always first look at the reliability. Okay, this looks fine, right? It's a theta fast. Again, done with the stimulus 3. Do we need to note this? No. Let's quickly see the grayscale. Let's quickly see this. This is the tip I am giving you. So grayscale, what do you see here? So blind spot is here and there is a scotoma which is merging at the macular area along with the blind spot. Can we see that? All this is black. Black is the decreased sensitivity of scotomatous area. The same when I look at the p-value, probability of the pattern deviation, I do find this. There is the area of blind spot. Of course, this is the area of blind spot where we don't note anything. Can we see here? This, the same here. And this is also, these are the areas of decreased sensitivity till macula. So actually this is, if I draw for you, any scotoma, this is the blind spot, this is the macula. When a scotoma touches both macula and blind spot, what do we call this? You draw this diagram. This is, you are looking at centrocecal scotoma. Okay. So we are looking at centrocecal scotoma. We will see the next chart. Okay. Let us look at the gray side. So if this is the blind spot, right? So left eye with the blind spot here. This is the area of decreased sensitivity that I see, light sensitivity, right? And when I am looking at the p-value, again I have these scotomas which is seen in the supero-nasal quadrant. This is how I will see and describe and understand. That means there is a problem, there is a scotoma. And again, if I look at the other eyes, both eyes are given here. So along with this blind spot, this scotoma has finally involved whole of the supero-temporal quadrant here, isn't it? So we have to keep this in mind. So this is all towards the blind spot. The quadrant will be supero-temporal, right? If it is blind spot is always temporal. Don't forget that, right? So you can see this here. Yeah, this is again, look at this one. What is this pattern? Look at this is only the gray scale it is showing. See the gray scale? Oh my God. It's like this. Look at the diagram. This is what is called clover leaf pattern. The age of the patient is 68. Now look at the reliability. This is first that I have told you always. Look at this. 63% is false negative. 63% is false negative. So it is not reliable. I will not comment on this. This is called clover leaf pattern. Okay, it's not reliable. It's a clover leaf pattern. Let's see the next one. Okay, let me first check the reliability indices. It seems fine to me, right? It's a theta fast done. Grayscale is showing all superior arcuate scotoma. Let me see the probability. Yes. So I see this is all affected. It is a superior arcuate scotoma, right? So this is the blind spot here, this area, which is shown here. So it's a right eye with superior arcuate scotoma. Okay, come to this one. Let's see this one. What do we see here? Okay, so this is the blind spot, it's a right eye. I am seeing some decreased sensitivity in the infero-nasal part. If this is the blind spot, this is infero-nasal, correct? So, yeah, so this field effect where this is what is called nasal step, which I was telling you, right? So this is the inferior nasal step. Nasally and inferiorly, I see some areas of decreased sensitivity compared to the superior. So it's like a step. So this is your nasal step, inferior nasal step, right? So this slide will be nasal step. So it is generally, see, rest of the areas, can you see it is all normal? I don't see anything else except the nasal. So it can be a case of, it is like an early change only, the glaucoma in this case. Now this is again grayscale and this is showing. So I think everybody is clear, this is inferior arcuate scotoma. Again this seems to be superior arcuate scotoma. Reliability is fine? Yes, it is fine. Okay, this seems to be more like a same thing except that it is more aggravated. Look at the, if you compare the two superior arcuates, there must be some areas of 0.5, some are less, but here it is all black, right? It is progressed and it is now involving the inferior part as well, right? So just look at the grayscale, look at this.